between COVID-19 vaccination and development of Alzheimer's disease. Ji-Hoon Ro. In-hung. Yoon-sun Soo.
Min-ho Kim.
QJM. An International Journal of Medicine, Volume 117, Issue 10, October 2024, pages 709 to 716, May 28, 2024. Article History. PDF. Views. Site. Permissions. Share. Abstract. Background. The challenges of the COVID-19 pandemic extend to concerns about vaccine side effects, particularly potential links to neurodegenerative diseases such as Alzheimer's disease, AD. AIM. This study investigates the association between COVID-19 vaccination and the onset of AD and its prodromal state, mild cognitive impairment, MCI. Design. A nationwide, retrospective cohort study leveraging data from the Korean National Health Insurance Service was conducted. Methods. The study, conducted in Seoul, South Korea, analyzed data from a random 50% sample of city residents aged 65 and above, totaling 558,017 individuals. Participants were divided into vaccinated and unvaccinated groups, with vaccinations including mRNA and cDNA vaccines. The study focused on AD and MCI incidences post-vaccination, identified via ICD-10 codes, using multivariable logistic and Cox regression analyses. Patients with vascular dementia or Parkinson's disease served as controls. Results. Findings showed an increased incidence of MCI and AD in vaccinated individuals, particularly those receiving mRNA vaccines, within 3 months post-vaccination. The mRNA vaccine group exhibited a significantly higher incidence of AD, odds ratio or 1.225, 95% confidence interval CI, 1.025 to 1.464, p equals 0.026, and MCI or 2.377, CI, 1.845 to 3.064, p less than 0.001, compared to the unvaccinated group. No significant relationship was found with vascular dementia or Parkinson's disease. Conclusions. Preliminary evidence suggests a potential link between COVID-19 vaccination, particularly mRNA vaccines, and increased incidences of AD and MCI. This warrants the need for further research to elucidate the relationship between vaccine-induced immune responses and neurodegenerative processes, advocating for continuous monitoring and investigation into the vaccine's long-term neurological impacts. Open a new tab. Download slide.
Topic.
Parkinson's disease, Alzheimer's disease, vascular dementia, immune response, DNA complementary, health insurance, internship and residency, neurodegenerative disorders, RNA messenger, vaccination, vaccines, international classification of diseases, Cox proportional hazards models, medical residencies, minimal cognitive impairment, South Korea, Seoul, mRNA vaccines, COVID-19 vaccines, issue section, original article, introduction. The emergence of coronavirus disease 2019 COVID-19 pandemic caused by severe acute respiratory syndrome coronavirus 2 SARS-CoV-2 in late 2019 swiftly necessitated the development of effective vaccines, leading to an unprecedented global vaccination campaign. Point 1. The rapid pace of these vaccines' development and their critical role in controlling the virus spread and reducing disease severity have been remarkable. Point 2. For despite the demonstrated efficacy of COVID-19 vaccinations in preventing severe illness, hospitalizations, and deaths associated with COVID, concerns about potential long-term side effects remain a subject of ongoing research and public concern. Point 6. Alzheimer's disease, AD, a progressive neurodegenerative disorder, represents a significant public health concern, especially with an aging global population. Point 7. The complex etiology of AD, influenced by genetic, environmental, and lifestyle factors. 8. Makes understanding any potential links between widely administered COVID-19 vaccines and the development or progression of AD crucial. Yet, to date, there is a scarcity of data on this potential association. Point 9. Given the potential association between long COVID syndrome and neurodegenerative disorders, it would also be important to assess subjects who receive vaccinations but do not yet have long COVID syndrome to better understand the association between COVID-19 vaccination and the development of the AD continuum. Point 10. 11. This report aims to explore the potential association between COVID-19 vaccination and the development of AD and its prodromal state, mild cognitive impairment (MCI), by examining National Health Insurance Service (NHIS) data from Seoul, South Korea. The study's strength lies in its large sample size and the use of the comprehensive NHS database and the early assessment of subjects before the Omicron pandemic to better describe the nature of COVID-19 vaccinations beyond or before the effect of long COVID syndrome on AD development. Methods. Data source. This retrospective cohort study analyzed data from the Korean NHIS, selecting a random 50% sample of Seoul's population residing in the city as of January 1, 2021, to assess the incidence of AD and MCI following COVID-19 vaccination. The dataset, detailed with medical records from 2020 to 2021, adhered to the International Classification of Diseases, 10th Revision ICD-10, for consistent disease categorization. Point 12. This study was performed in accordance with the ethical standards as laid down in the 1964 Declaration of Helsinki and its later amendments, and was conducted following the strengthening the reporting of observational studies in epidemiology, STROBE guidelines, enabling a detailed population-based cohort analysis. By utilizing the extensive medical claims and diagnostic data from the NHIS. Point 13. Study population. This study encompassed 4,348,412 Seoul residents. This study encompassed 4,348,412 Seoul residents, randomly selected from the NHIS, amounting to half of the city's population as of January 1, 2021. After excluding individuals under 20 years, 4,203,887 people remained for analysis. As of September 30, 2021, 3,839,014 were identified as vaccinated and 364,873 as non-vaccinated. Inclusion criteria were limited to individuals who had received both doses of the COVID-19 vaccine by September 30, 2021. Those who did not receive their second dose by this deadline were omitted. Consequently, 2,154,389 vaccinated and 350,953 non-vaccinated individuals were left after further excluding deceased subjects. The index date for vaccinated individuals was the date of their second dose received by September 30, 2021, while for non-vaccinated individuals, it was established as October 1, 2021. Ultimately, 558,017 individuals aged 65 or older, 519,330 vaccinated, 38,687 unvaccinated, were included in the analysis. Figure S1 in the supporting information. Table 1. Table 1. Open a new tab. Baseline characteristics of the participants stratified by COVID-19 vaccination. A potential association. To assess the link between vaccination and the onset of specific diseases, medical records from a year prior to the index date were reviewed and participants with any record of the pertinent diseases during this period were excluded. Figure S1 in the supporting information. The onset of the diseases was marked by a primary or secondary diagnosis after the index date. Diseases were identified using ICD-10 codes, covering a range of conditions including MCI-AD, vascular dementia, other forms of dementia, Parkinson's disease (PD), neurodegenerative disorders, cranial neuropathy, autonomic dysfunction, insomnia and obesity. Point 14. Detailed definitions of each ICD-10 code are provided in Table S1 in the supporting information. Briefly, AD was defined when the diagnostic code of F00, dementia and Alzheimer disease, or G30, Alzheimer disease, was registered. MCI was defined when the diagnostic code F06.7, mild cognitive disorder, was registered. Outcome measurements. The incidence of AD and MCI in the vaccinated population was compared with that in the unvaccinated population after controlling for potential confounders. Multivariable logistic regression and Cox regression models were employed to assess the association between COVID-19 vaccination and subsequent MCI and AD development. We also investigated the incidence of post-vaccination vascular dementia and PD as control groups for AD to better understand the potential causes underlying abnormal protein aggregation after the vaccination. The study measured the cumulative incidence rates of MCI or AD per 10,000 individuals, comparing vaccinated and non-vaccinated groups at intervals of 1 week, 2 weeks, 1 month, and 3 months post-vaccination. The covariates included were gender, age, insurance level, Charlson Comorbidity Index, CCI, 14 diabetes mellitus, hypertension, hyperlipidemia, chronic obstructive pulmonary disease, and a history of previous COVID-19 infection. The identification of comorbidities and previous COVID-19 infections was based on primary or secondary diagnoses recorded at least twice within the year preceding the index date. Participants were categorized into 4 groups according to their vaccination status: unvaccinated, mRNA vaccine only, cDNA vaccine only, and a combination of the two. The mRNA vaccine-only group received the Pfizer-BioNTech, BNT162b2, or Moderna mRNA-1273, vaccines for both doses, while the cDNA vaccine-only group completed the Oxford-AstraZeneca, ChAdOx1nCoV-19, or Johnson & Johnson Ad26 vaccines. A heterologous vaccine group consisted of individuals vaccinated with both mRNA and cDNA vaccines. The National Health Insurance (NHI) premium, reflecting monthly income levels including earnings and capital gains, was used as a proxy for income. The study categorized participants into 3 income groups: low, middle, and high, based on medical aid enrollees and percentiles, 0 to 33%, 34 to 66%, 67 to 100% among NHI enrollees. The CCI diseases were monitored, and participants were classified as having a CCI score of 0, 1 or greater than or equal to 2, based on primary or secondary diagnoses. Statistical analysis. Statistical evaluations in this study were conducted using SAS Enterprise Guide, version 8.3, SAS Institute, Cary, North Carolina, USA. The distribution normality of the data was verified using the Kolmogorov-Smirnov test. We presented baseline characteristics as means plus or minus standard deviation for continuous metrics and as frequency percentages for categorical factors. The impact of COVID-19 vaccination on the occurrence of MCI or AD was analyzed using students' t-test for continuous variables and chi-square or Fisher's exact tests for categorical variables. The cumulative incidence rates were calculated as occurrences per 10,000 individuals. Multiple logistic regression was employed to determine odds ratios, ORs, and their 95% confidence intervals, CIs, for the association between COVID-19 vaccination and MCI or AD development. Cox proportional hazards models were utilized to compute hazard ratios, HRs, and their 95% CIs. A p values threshold of less than 0.05 two-sided was set for determining statistical significance. Ethical approval. Results. The study was approved by the Institutional Review Board of the UA Women's University Hospital, IRB No. UMC 2022-07-003, and the requirement for informed consent was waived by the IRB. All data were anonymized before retrieval. Results. Baseline characteristics of the participants stratified by COVID-19 vaccination status are provided in Table 1. In individuals with mRNA vaccination only, the 3-month post-vaccination incidence was significantly higher for MCI, or 2.377, 95% CI, 1.845 to 3.064, p less than 0.001, and AD, or 1.225 CI, 1.025 to 1.464, p equals 0.026, compared to those unvaccinated. Individuals who received cDNA vaccines only, or 1.763, CI 1.348 to 2.306, p less than 0.001, and cross-vaccination or 2.114, CI 1.267 to 3.525, p equals 0.004, also exhibited a significant increase in MCI incidence compared to those unvaccinated. Table 2. The risk of developing MCI and AD after the vaccination remained unchanged, particularly in the mRNA vaccination group, compared to the unvaccinated groups. The HR for MCI in individuals vaccinated only with mRNA vaccines was 2.342, 95% CI, 1.818 to 3.018, p less than 0.001, with cDNA vaccines only was 1.742, 95% CI, 1.332 to 2.278, p less than 0.001, and with heterologous vaccination was 2.088, 95% CI, 1.253 to 3.481 p equals 0.005. For AD, the HR in individuals vaccinated only with mRNA vaccines was 1.209, 95% CI, 1.013 to 1.444, p equals 0.036. Table 3. The study found no significant association between COVID-19 vaccination and the development of vascular dementia and PD. Table 4. Table 2. Open a new tab. Odds ratio or of mild cognitive impairment, MCI, and Alzheimer's disease AD, following COVID-19 vaccination. Discussion. This nationwide population-based study explored the incidence rates of AD and MCI following COVID-19 vaccination in Seoul, Republic of Korea, revealing a higher incidence in the vaccinated group compared to the unvaccinated group. Notably, this increase was observed as early as 12 weeks post-mRNA vaccination, suggesting its potential temporal association with the onset of AD continuum. The observed trend raises questions about the role of vaccine-induced immune responses in neurodegenerative processes. COVID-19 vaccines, particularly mRNA types, are designed to elicit robust immune response. 15 This response could potentially influence the pathogenesis of AD, characterized by abnormal protein aggregation, namely amyloid beta plaques and tau tangles. 16 As the mRNA encoded in the SARS-CoV-2 vaccine is known to cross the blood-brain barrier, or at least disrupt the barrier, the SARS-CoV-2 spike protein might interact with amyloid beta proteins, affecting their aggregation and influencing microglial activation. 17 This interaction may potentially exacerbate the cognitive decline associated with AD by promoting an environment conducive to inflammation and protein misfolding. 17 Additionally, lipid nanoparticles in mRNA vaccines can activate toll-like receptors, leading to inflammatory reactions that might exacerbate neuroinflammatory pathways associated with AD pathogenesis. 17. Such inflammatory reactions may trigger a cytokine storm involving interleukin-1 beta and tumor necrosis factor alpha, which have been implicated in both acute and chronic neuroinflammatory responses that accelerate the progression of AD. 18 Furthermore, N1-methylpseudouridine in mRNA vaccines may cause ribosomal frame shifting during translation, resulting in aberrant protein products that could contribute to neurodegenerative processes. 19 These aberrant proteins could disrupt normal cellular functions, including autophagic processes, and thereby lead to the accumulation of neurotoxic protein aggregates that are hallmark features of AD. 20 Albeit not confirmed, the molecular mimicry related to S protein formed by SARS-CoV-2 vaccine should also be considered as a source of autoimmune responses potentially exacerbating AD pathology. 21 Moreover, vaccines could induce a cascade of low-level neuroinflammatory responses, known contributors to the development and progression of neurodegeneration. 9 Further exploration of these mechanisms could provide additional insights into the long-term effects of mRNA vaccines on the central nervous system and their potential link to neurodegenerative diseases, including AD. The higher incidence of AD post-vaccination in older individuals and females might reflect demographic differences in AD, as well as an immune response to vaccines. older adults often exhibit a heightened inflammatory response, which could predispose them to faster progression of neurodegenerative diseases. Point 22. Similarly, sex differences in immune system functioning could account for the increased susceptibility observed in females. Point 23. The distinct post-vaccination effects were not observed in the development of vascular dementia, compared to the results from MCI and AD. This lack of association suggests that the observed increase in AD continuum incidence post-vaccination might be specific to Alzheimer's pathology and not to the vascular etiologies of dementia. Table 4. No increase in the incidence and risk of PD after the vaccination, in line with the previous report. 9 may indicate a potential link between COVID-19 vaccination and abnormal aggregation in specific proteins, which findings need to be verified in long-term follow-up studies. Table 4. We excluded participants with prior diagnoses of pertinent diseases, including MCI and AD, from our study to reduce the risk of reverse causation. The absence of an increase in HRS in PD and vascular dementia also supports the strong association between COVID-19 vaccination and AD continuum. If reverse causation was at play, we would expect to see similar effects in other neurodegenerative or acute neurological conditions like PD and vascular dementia. However, despite these efforts and findings, the potential for reverse causation cannot be entirely ruled out. The early increase in the incidence of AD continuum may have also contributed to the initial vaccinating policy of the country, such that the elderly or those with illness, who may have a higher risk of AD or MCI, were more likely to be vaccinated at the beginning. The study's strength lies in its large sample size and the use of the comprehensive NHS database. However, there are limitations that need to be addressed in future studies. First, the major limitation is the short duration of follow-up, up to 3 months, given that AD is a chronic neurodegenerative disorder. The low prevalence of COVID-19 infection in the cohort, coupled with the study's timing before the Omicron pandemic, also limits the assessment of long COVID effects on AD. In the meantime, from a different perspective, it is worth noting that this cohort can be a platform to better describe the nature of COVID-19 vaccinations beyond or before the effect of long COVID syndrome on AD development. It is also notable that the incidence and risk of development of MCI and AD after mRNA vaccination became more prominent by 12 weeks, which warrants future studies with longer follow-up periods. Especially, datasets including post-Omicron wave will be crucial to understanding the long-term impact of COVID-19 and vaccinations on development and progression of the AD continuum. Second, this study focused on specific population, sole residents, aged greater than or equal to 65. Thus, the findings may not be generalizable to other populations or age groups and warrant further investigation in both domestic and international cohort with a broader range of ages. Third, while this study explored the implications of COVID-19 vaccinations on AD, it is also essential to consider the findings from studies that indicate the protective effects of other vaccinations, such as flu and shingles vaccines, against AD development. 25. This aspect highlights the need for comprehensive research into how various types of vaccinations might influence AD risk. Fourth, the diagnostic accuracy of MCI and AD based on records from a nationwide database such as NHIS may be less precise than diagnoses derived from detailed neuropsychological tests, brain imaging, and additional biomarkers that assess neurodegenerative changes. A recent literature on the AD diagnostic accuracy by comparing diagnostic codes alone versus diagnostic codes plus medication history revealed that the latter underestimates the actual prevalence of the disease. 26. Conversely, diagnosis based solely on codes closely approximates the real prevalence of AD, a method we have adopted to assess the development of MCI and AD in this study. 26. Overall, the beneficial effects of COVID-19 vaccination, which have clearly improved mortality and morbidity associated with COVID-19, cannot be overlooked. 2. For this study provides preliminary evidence of a potential association between COVID-19 vaccination and increased incidence of MCI and AD. While the findings highlight a need for cautious interpretation, they demonstrate the importance of ongoing surveillance and research into the long-term effects of COVID-19 vaccines on AD continuum. Further research will also need to include prospective human studies and preclinical investigations into the underlying biological mechanisms, especially those involving abnormal protein aggregation and neuroinflammation. This comprehensive approach will enhance our understanding of the risk-benefit balance of COVID-19 vaccinations, particularly in populations at risk for neurodegenerative disorders. Acknowledgements. The authors appreciate the conceptualization of the study and the generous sharing of data by CM. Author contributions. Ji-Hoon Roh conceptualization equal, data curation equal, formal analysis equal, funding acquisition lead, investigation equal, methodology equal, project administration lead, resources equal, software equal, supervision lead, validation equal, visualization equal, writing, original draft equal, writing, review and editing lead, In-Ha Young formal analysis equal, investigation equal, visualization equal,